I want to welcome everybody. My name is Mark Stern. I'm a correctional physician. I wear a few hats, but one of the things I do is I work with WASPC, the Washington Association of Sheriffs and Police Chiefs, on healthcare-related issues. Today's meeting is mostly to look at a demonstration of something called CDR, the data repository, clinical data repository of information about Medicaid patients. Before we get into that, I'm going to want to give everybody a little bit of a background, especially the people from the jails and prisons and juvenile justice, all three of whom are here. And then I want to do a couple of introductions and then finally turn it over to the folks from One Health Port to do the demonstration, and we'll have a little discussion. So in terms of background, it's important for those of you who are taking care of patients in the jails, prisons, and juvenile to know that most of our patients are either eligible for or covered by Medicaid. And if somebody signs up for Medicaid, I'm going to share my screen now. Oops. Sorry about that. If somebody signs up for Medicaid in Washington State, they end up picking one of these 5 companies to get their insurance from. So it's not directly from Medicaid, it's through one of these companies. And these 5 companies all operate in Washington, but they don't all operate in every county in the state. So here's a map of Washington State and where each of the companies are. Each company is, the state is divided up into these different color-coded areas. And let me just show you as an example, if you happen to be in Clallam or Jefferson or Kitsap County, you're in the Salish group. And in that particular area, there are only 3 of the companies that are the Mera Group and Molina and United that have patients in those 3 counties. So I'm going to go back to this first map and let you guys take a look at it and kind of identify your own county and see which are the MCOs. They're called managed care organizations or insurance companies that are operating in your county. Now, that doesn't mean that you might not have a patient in your jail or prison who's from another county where they have their insurance carrier, their MCO is a different company, but if they live in that county, they would most likely be with one of these companies. All right, so that's kind of that overview. So it turns out that the MCOs, the managed care, these 5 managed care organizations have an important role in helping us with taking care of our patients in the correctional setting. Now, as you know, with a couple of small exceptions, they don't, Medicaid doesn't actually pay for health care when people are in jail or prison, but they have an important role in helping coordinate the care for people both when they come into the jail, and so that's one role for the MCOs to help coordinate and make sure there's continuity of care. And also at the back end, when somebody leaves the jail, they also have a responsibility for helping to make sure that, again, the care is coordinated as somebody comes back in the community. So that's very, very important. Because of this important role, to this end, Representative Lauren Davis from Washington's 32nd District, who I'll introduce to you guys in a moment, has been holding meetings with WASPC and Healthcare Authority and the MCOs to try to help improve this connection that MCOs are supposed to help us with, the front end and the back end. And one outcome of that a couple of weeks ago was a meeting. It was arranged by John McGrath, who's also on this call, who I will introduce to you in a moment, who's the liaison at WASPC between WASPC and the jails. And the outcome of that meeting, or the progress in that meeting, was to help improve that connection that the MCOs have, the coordination role that they have with helping to get patients integrated back into the community, make sure there was continuity of care. A few weeks ago, Representative Davis invited me to one of these meetings between WASPC, Healthcare Authority, and MCOs. And during that meeting, we all discovered a tool that's available called the CDR, which is, we're going to be talking about a little bit more, a lot more today, which has clinical information about Medicaid patients. And what we all realized is that that tool might be able to play a really important role in the front end when people are coming into jail to provide us with some information about them. And so when we came to that realization, Jason McGill, who's the Assistant Director for Medicaid Programs at Healthcare Authority, who I also will introduce you to in a moment, arranged for us for One Healthport, who operates this this clinical repository, this clinical data, to do this presentation for us today. So our plan for today is mostly that to take a look-see at this clinical repository, and have a demonstration and then do some questions and answers. It's not a goal of today to walk away with immediate access to the CDR. There are some kinks and details to work out, and which will take some effort. And I didn't want us to all spend a lot of time trying to work out those kinks if this turns out to be a tool that is not of interest to the clinicians in the jails, prisons, and juvenile justice. So really what we're looking for today is for you guys to take a tour of it, see if it makes sense for you, if it's a thumbs up or thumbs down. And if it is a thumbs up, then we'll all go back to work and try to do make a coordinated effort to make this all available to the correctional healthcare providers. So on that note, let me introduce you to the people whose names I've teased. First, let me ask Representative Davis to say a word and welcome us.
Awesome. Well, first of all, hi, everyone. I'm Lauren Davis. I, as Dr. Stern said, represent the 32nd Legislative District, and I spend most of my time in the legislature working on two issues: behavioral health and the criminal legal system, and obviously incredible overlap between the two. And consequently, those are the committees I serve on in the legislature as well. I mostly just want to say thank you to all of you for being here, for your time. This is incredibly exciting to me. Huge hats off to Dr. Stern, who, in case you didn't know, does like 99% of what he does as a volunteer out of the goodness of his heart. And he could be literally retired in Bora Bora, but chooses to the gift of his time and his significant expertise to be doing this. I would say this meeting wouldn't be happening without him, and clearly he's pulled this group together. So just thank you, Mark, for that. And yeah, I'll just add the tiny bit of context to say, so I serve on the House Public Safety Committee, work on jails and prisons. I sit on the House Healthcare Committee, and I'm fairly new in the legislature. I've only been there for 3 sessions, and I'm spending a lot of my time working on that Venn diagram overlap of those two. And that's also my professional background. I work in behavioral health, and I at some point stumbled upon the language in the managed care organization contracts that actually say that they have the following obligations for an individual who belongs to a managed care company. So any Medicaid recipient, when their Medicaid recipient, their plan enrollee, comes into custody, they have to do several things. They have to identify the individual at the particular correctional facility who's responsible for health care or care coordination for this individual, and transmit patient health information, including things like prescription medications, behavioral health needs, a significant medical history, which again, if that were happening, would hugely improve the quality of care that we're able to deliver to individuals in custody, healthcare and behavioral health care. And then that's on the front end. And then on the back end, they're supposed to do care coordination to include medical needs, behavioral health needs, transportation, housing, and it's supposed to be evidence-based care coordination. Now we have a long way to go to make sure that those things are actually happening across our correctional facilities. And I think we're pretty early in that process, but I'm really hopeful and really excited and really grateful for all of you coming together. And I hope that CDR potentially is one tool to allow the transmission of clinical information for the end goal of really quality patient healthcare. So that's all I've got. Thank you.
Sorry, I was on mute, wrong button. Jason?
I was just going to ask you, Mark. Okay. Hey, thanks, Dr. Stern. Thank you, Representative Davis. And I won't say much more than thank you to the One Healthport team and to the HCA team, in addition to all of the work you do out in our communities, our jail teams and our MCOs to help with this work. We've got a lot of work to do to improve the system, and we intend to do that. CDR is, I think, just one tool. We'll have a work group that the Senate legislation that also passed will form to help with, I think, these ongoing conversations. We will also be focused on, thank you to WASPC's efforts to get us authority to share booking level data where people are booked as part of our daily download data to the MCO. So that should be available. I don't have a timeline on that yet, but certainly over the next few months here this year, hopefully. And a host of other work to and try to improve the system. The MCOs, I think the managed care organizations are very engaged and looking forward to improving this work. And again, this CDR component is just one element of the big picture here. And particularly, I think you may be useful if and when we can get to a point of actually sharing some clinical data between providers, jails, MCOs, while before their people enter jail, after people exit jail. So anyhow, look forward to the conversation, and thank you again for joining us today. Thank you, Dr. Stern, for helping organize this.
My pleasure. Is there anybody else, Jason, from Healthcare Authority that you need to introduce, or are we good?
I think that's good for now. Just a great team here, and I think we'll be meeting each other as we work together on these issues going forward. I do see Dr. Sharisa Fatinos on the line. Hi, Dr. Fatinos. Just a wonderful, our key behavioral health medical director expert. I see Amy Dobbins, our eligibility expert, Jessica Diaz on our team, managed care team, who are really spearheading some of this work. And of course, our One Healthport and CDR team. Thank you all for joining as well.
Thank you, Jason. And John, if you would introduce yourself.
Good morning, I'm John McGrath. I'm the Jail Services Liaison for WASPC. And I just want to say thank you for all of you joining today. I appreciate the work that you do. Yesterday started the National Corrections Officer Week. So just thank you for all the corrections officers that are here today and the work that you do for our communities.
Hooray, thank you. Wonderful.
So on that note, we will jump into the presentation. We have Rick Rubin, who's the CEO of One Healthport, the company that that runs the CDR, and we have Joe Rao, who is the Senior Product Manager for One Healthport, both of whom are content experts and will walk us through things. Joe, I've already given you a host, so go ahead and drive, and it's all yours.
All right, thank you everyone. Good afternoon. I am sharing a screen which says Clinical Data Repository. Can everyone see it?
Yes.
Yes. Perfect. Before I begin, I'd like to quickly introduce myself and Rick, and then Rick will start the presentation with some background information, and then I will delve into the demo. Before we get started, a few housekeeping items. Could you all please mute your Zoom calls so that there's no background noise and doesn't disturb anyone else? Also, as we go through the demo, I think a lot of the questions are going to be answered as I go through the demo. However, if there are any immediate questions, please do stop me and ask me the question. If not, if you think you can hold off till the end of the demo, that will be fine too. Probably at the end might be preferable in case your question gets answered as part of the presentation. With that, Rick, would you like to introduce yourself and kick off this demo?
Great, thanks very much, Joe. Good afternoon, everyone. My name is Rick Rubin. I am the CEO of One Healthport. I'm very pleased to be able to talk with you today. Representative Davis, Dr. Stern, Jason, and everyone else on the call. We really appreciate you spending some time with us today. This is the agenda. We're going to give an overview of the clinical data repository. You'll hear us use the term CDR. Apologize in advance for that. We felt we didn't have enough acronyms in health information technology, and that we would fill that gap by adding one more for you. Joe is then going to do a demonstration of the portal so you can see how it really works, the view that you would have as a clinician, and then we'll take some questions and next steps. Next slide, please, Joe. So we're not going to spend a lot of time on this, but just so you know who we are, One Healthport is a private company. We're owned by a number of local healthcare companies. We occupy this unique role. We are the lead organization for health information exchange and actually administrative simplification in Washington. That was created by the legislature in 2009. And basically they charged us with running this like a business, but in the public interest rather than in the interests of our shareholders. And so we really act like a public utility for health information. That's the best way to understand us. And our work on the clinical data repository comes to us in that capacity. We really appreciate all the work that the healthcare authority, the managed care organizations, the providers who submit data have done over the last few years to create the clinical data repository that we're going to show you. And our role is to coordinate that work and manage it. At the simplest level, the clinical data repository is a place where we aggregate clinical data and we provide those who are authorized access. And the purpose of doing this is to improve both the health of individual patients and populations. This is a tool that allows individual clinicians to look at information about individual patients. But as you can all imagine, by aggregating all this information, it allows us to look in aggregate at the population. And there are a variety of analytic approaches that we will not be talking about today that we could use. Currently, the CDR stores 3 types of data that are relevant to what we're talking about today. Number one, demographic data. As I was listening to the early parts of this conversation, as with so many things in healthcare, it comes down to identity. If you're going to be helpful to a patient, or you need to understand who that distinct person is, and you need to be able to match what has happened to that person and know that it is in fact that person. That my name, Rick Rubin, there are other Rick Rubins, and it's really important to know which Rick Rubin you're talking about. So we start with demographic data, and we're lucky. We get eligibility data for all managed Medicaid enrollees. And that's frankly easier from a matching perspective than just collecting random data from lots of individual patients out there. So this cuts across all the managed care plans that Dr. Stern described for you. Second, we get claims data. So a claim, as you all know, is what a provider sends when they're requesting payment from a health plan. The plan pays that. We do not store the financial data. Our purpose as a clinical data repository is to take the clinically relevant data elements from those recent managed care organization claims. And again, one of the advantages is we're covering all the managed care organizations. So we've got quite a bit of claims data. And then last but not least, the clinical data, which are clinical summaries from providers who treat managed Medicaid enrollees. Anybody who's worked with an electronic health record, you know that those electronic health records are designed to export standardized clinical summaries. They happen to be called CCDs, just to have a few more acronyms. And we receive those CCDs from those electronic health records from providers who treat managed Medicaid enrollees. Currently, we have about 2.2 million patients in the CDR. If you're curious as to why that number is larger than the number of people enrolled under Medicaid managed care, it's because, as you know, people bounce in and out of Medicaid managed care, and therefore the healthcare authority and the managed care plans have assisted us to be able to continue to store those records for people while they may be bouncing back and forth. Next slide, please, Joe. So I wanted to share this slide with you to set some context because, you know, candidly, people often accuse information technology vendors of selling vaporware. In my own experience, there's probably some truth to that. And we do not want to sell you vaporware. We want to be very upfront about what the system does today and what it does not do. You know, I would hope when you finish this presentation that you'll see the glass as half full. I think Joe's going to show you some things that will be very useful to you. but there are also some limitations. So let's talk about those limitations up front. So as you're looking at this, it will help you think about how this can and cannot be useful to you today. So number one, right now the CDR is focused only on managed Medicaid. As I mentioned, we have all the active managed Medicaid, and we have some of the folks who bounced in and out. Not all providers submit those CCDs, that clinical data. The Healthcare Authority has worked with their colleagues in the provider community, and there are a variety of reasons why it's been difficult for some providers to submit clinical data. So we have a lot of clinical data, but we do not have it from all providers. Some data is excluded. The Healthcare Authority feels very strongly that they have responsibility for this information. They want to be very respectful and attentive to issues around privacy of the individuals involved. And so there are some consent issues that we have to resolve around behavioral health information. And while I know that that is an important data set to you, right now that information is not in the CDR. I think it's also important to understand that, like much of the health information infrastructure, the CDR is a work in progress. There are lots of cool things going on in our world. We're starting to see for the first time real national health information exchange networks that allow us to have access to electronic health records all over the place. We have information blocking regulations that require providers to agree to send data for authorized purposes. We have scalable infrastructure. One of the things that's very exciting as you think about behavioral health, we are working with the Healthcare Authority on a potential pilot for consent management, and that would allow us to potentially receive more behavioral health and 42 CFR information. And last but not least, there's a lot of excitement about new data sources that we could put in the CDR, social determinants of health, and certainly information around incarceration could be an important part of that, patient assessments, behavioral health screening, and so on. So again, I think you're going to see a lot of good stuff that Joe's going to show you shortly. We have some good information for you. And there are some things that won't be there, and we're very excited about what comes next. And with that, I am going to turn it over to my colleague, Joe Rao, who is going to show you the CDR and talk with you about how it can be helpful to you in your work. Thanks very much.
Thank you, Rick. Before I get started on the CDR, are there any urgent questions or something that we can help answer before we move forward?
Let me ask Rick a question or clarify. So currently the federal regulations limiting the behavioral health information, that includes the substance abuse information too, is that correct?
Yeah, the federal regulations you're referring to really relate to a very limited class of information around substance use treatment in very specific circumstances. The challenge that we've wrestled with the Healthcare Authority is, as you folks know on the clinical side, that information is often inextricably bound up with other behavioral health information. And so that's really why the Healthcare Authority, I think, has taken the conservative course to date, and we are working at trying to find a path through that.
Can I add to that? This is Teresa Fatinos from the Healthcare Authority. We do have the behavioral health, mental health data in there, but what we're not able to do at this point is distinguish the entities that hold themselves out as 42 Part 2 providers, which requires the consent that Rick was referencing, from general medical providers who are making the diagnosis of substance use disorders, but who are not in the eyes of 42 CFR Part 2 seen as substance use disorder providers. And that sounds technical, and it is, but the challenge is trying to figure out how to assign those properly so that the information that can be shared is able to be for the folks that can see it. So we're working on that. It's just that parsing out has been a challenge and continues to be so.
Thanks, Teresa. Joe?
All right, thank you, Teresa and Rick. I will sort of repeat what Rick had mentioned by going through what data is available in the clinical data repository with an example. And I'm going to bring up an example of, let's say, Sarah. Sarah is a managed Medicaid client. Let's say she went to Neighbor Care Health in January and was diagnosed with hypertension. Neighbor Care Health as a provider, because they saw a managed Medicaid client, are required to electronically submit the clinical information to the clinical data repository with something known as the continuity of care document, CCD, that Rick had mentioned before. I know that sounds very technical, but let me explain what a CCD is. A CCD is really a summarization of the care that was given to the patient. For example, it bundles up all the problems that the patient has, all the procedures that were performed, medications, labs, vitals, any allergies the person has. So it just bundles that up and sends it in an electronic format, almost real time, I would want to say. So if the patient was seen today, the minute the encounter has been closed, which is anywhere from 24 hours to about 70 hours, a continuity of care document is electronically created and sent automatically to the clinical data repository. Once the connection has been set up, the provider doesn't have to do any additional work. It's a system-to-system connection where this clinical information is freely flowing from the provider's office to the clinical data repository. Now, let's say the same patient, after about 3 months, say in April, they had a hand injury and turns up at University of Washington emergency department and gets seen there. A similar CCD or clinical information gets generated and sent to the clinical data repository. So you can see how over time, when we aggregate clinical information for Sarah, we can see a longitudinal view of what care has Sarah received over time. So that would be the most advantageous thing, because irrespective of where Sarah got care, which provider she saw, you can now start to see all the care that Sarah received over time. Likewise, from the different 5 MCOs that exist in Washington, we do receive claims information, all clinically relevant claims information. We don't get any financial information, but the claims information, such as all the medications that the patient picked up from the pharmacy, that could be very valuable information, because now as a clinician, not only do you know what medications were ordered for the patient, you can also see which medication Sarah actually picked up from the pharmacy. With that is how data gets into the clinical data repository. In the next slide, I'm going to walk you through the different ways you can actually get data out of the clinical data repository. For today's purposes, we really are going to focus on option 1, which is the ability to view this data through a portal, which is called the clinical portal. And I will walk you through a demo of the portal in a bit. However, before I delve into that, I do want to mention that technically option 2 and option 3, which I will talk about briefly in a bit, is also feasible. Option 2 really talks about, let's say that at a jail setting, you have an EHR, and the EHR is capable of what we say querying the clinical data repository. A query is actually a standard transaction, and any EHR, if you were to talk to them, do you support queries, they should be able to tell you yes or no. What that enables is a system-to-system exchange of information. So as a clinician, you don't have to log into a separate portal to be able to view this information. If your EHR was capable of querying, it would say, hey, I have a booked patient called Sarah. Do you have any additional information for Sarah in the clinical data repository? It would do an automatic query, get the relevant information back into the EHR, and the clinician would be able to see this additional information from the clinical data repository right in their EHR. And that is functionality that is currently technically available. But if that is something of interest to any of you and you would like to have further conversations about it, please do reach out to me after this demo and we can talk more about how we can take that conversation further. The last option that I want to briefly touch base is, if let's say as a jail, you do not have an EHR, but you have a list of patients that you'd like to see whether you can get additional information on, and you'd like to send electronically this list of patients, we could then get this list of patients, see what information we have on this patient, package it up and send it back to you so that you can review it on a periodic basis, whether it is daily or weekly or anything else. This last option does require HCA approval. We have not implemented it yet, but it is an option that generally when we talk in the marketplace, it seems to resonate. And I just wanted to bring it up if that is something that, as a marketplace, you think that might be a better way to go. However, for today's conversation, we really are going to focus on if you just had a computer and you wanted to view this information using a web portal, what would that look like? I'm going to pause and see if there are any questions before I move into the demo itself. Okay.
So at some point, question on SUD data came up, and I know there's some differences there that might be worth mentioning.
Okay, so maybe towards the end, I will look at chat and see what the question was, and then we can go from there, if that's okay.
Yes, perfect.
All right, thank you. Okay, prerequisites for viewing the data in the clinical portal. Before your organization can view data in the clinical portal, there are two main things that you need to figure out for yourselves. As One Health Port and HCA, we actually require you to define policies within your own organization as to who gets access to the data that's viewable through the clinical portal. We don't dictate for you as to who can or cannot get access. The way our delegated model works is that we ensure that your organization is really a legal organization. And then we assign an administrator to your organization. That administrator will rely on policies that you will develop to figure out who gets access to this information and who doesn't get access to this information. And the second thing that your organization will need to do is really sign a participation agreement with special terms. Now, let me explain what special terms means. It really means that when you sign the agreement, there is a section about what HIE participation fees. One Health Port is waiving this fee for all organizations who use the HIE only for viewing the data through the clinical portal. If all that your organization is doing is viewing data through the clinical portal, we will waive this HIE participation fee. However, the minute you start doing any other transaction, for example, if you were interested in a query or doing something else on the HIE, which we do support a lot of different providers for, then you will be assessed the annual HIE participation fee going forward from that point onwards. With that, I'll start the demo of the clinical portal. And the reason I bring up this slide is I'm actually going to do a demo in the test environment. And I wanted to show you if you were to get access to the clinical portal, you would actually go to the One Health Port website. Under CDR tab, you would actually click on the clinical portal tab, which has information on, how do you sign up for the HIE participation agreement, what training is available to you. But right at the bottom of the page, there is this button which you will click to get access to the clinical portal, which when you click will come up with, enter your username and password information. And once you have signed all the participation agreement, you will have a subscriber ID and password to log on with your information. I'm going to do the demo in a test environment, and I did not want to bring up the real patients up. Therefore, I was just showing you where you would go to log on to the clinical portal. With that, I am going to bring up I am currently sharing my screen, which says subscriber ID and password. Is everyone able to view it?
Yep.
Okay. I have my username and password entered already. I'm going to log in with my username and password. And then this is my screen where I choose this tab which says clinical portal. When I click on clinical portal, HCA requires that every authorized user into the clinical portal must have multi-factor authentication. This is just to make sure you're double sure that the user is who they say they are. And you're probably very familiar using multi-factor authentication for your banking applications and other applications. So I'm just going to bring up my Google Authenticator, which gives me a 6-digit code that is unique to my user ID that I enter to get access into the clinical portal. All right, I click on verify. And this is the home screen of the clinical portal. Now, you can notice that in the home screen, there is this tool up right here, which says find patients. There are different ways you can find patients. You can use, their first name, their last name, along with date of birth, or you can do it with their social security number. You can bring them up with their social security number. And all managed Medicaid enrollees in the state of Washington have something called the provider one number. So they're called the P1 number. If you happen to know their P1 number, you can enter their P1 number here and look for the patient that way as well. For today's purposes, I'm really going to bring up a person using their last name. And I put a wildcard asterisk so that any patient with, the last name as test patient, they will come up. And for the demo today, I'm going to select someone called Sarah test patient. As you can figure out, it is a fake made up patient. So if you're looking for clinically accurate information, it may not be 100% accurate because it's data that we made up. Now, at the top of the screen, when Rick mentioned about demographic information, that is where we see all the demographic information for the patient. And right here on the right-hand side of the screen, you can always click this to see. It usually wouldn't say OHP test insurance. It would actually say which MCO does this patient belong to. Do they belong to Molina? Do they belong to United? Do they belong to Amerigroup? It would actually say the name of the insurance company. When you click on it, you see some additional details about the patient. What was the effective date? What is the plan number? What is the provider one number? What policy do they belong to? So you'd see more information about that person's insurance information. Now, if I go back to just seeing the overview of the patient, on top is the demographic information. Everything you see at the bottom here is clinical information that has been aggregated on the patient over time that we received from different providers. For this example today, you see only that one provider sent an information continuity of care document for this patient. But in reality, you could see anywhere from, 1, sometimes 0 to like 20, 25 different continuity of care documents. Now, the advantage of actually bringing one up, and I'll bring one up just to show you what it looks like. The advantage of this is that every provider who submits this clinical information to the clinical data repository has to submit these required sections to the clinical data repository. They have to send allergies, immunizations, medications, problems, procedures, results, and vital signs. And this is the human readable form of the information that they've sent to the repository. While these are required sections, a lot of providers in our state also choose to send in additional information. So, for example, notes, discharge summary, or they would say, advanced directives, smoking status. There's a lot of additional information that a lot of providers do send. So sometimes clinicians actually like to bring up relevant documents just to see what else can be found in the document while they go through the notes for the patient. I'll go back to this information. So what you had seen was, they were sending medications and allergies and immunizations and problems. The one good thing that the repository does is that it extracts the relevant information for the required sections and puts it into the relevant tabs of the clinical data repository. So all the problems that were listed in the document will then show up in the relevant problem. So you can see that the person has acute bronchitis and hypertension. That was already there in the data that was sent across by the clinician. I'm not going to go into details of the various tabs of the clinical data repository, but all the relevant and required sections, you will see more information as you click through the different tabs. Before I go on, I would like to briefly mention that there is a button right on top. Sorry, was there a question before I moved on? Okay, maybe I misheard something. So there's a button right here on the right-hand side which says the claims view. I am not going to go into details here because I would, as per Dr. Stern's instructions, I think our time would be best utilized to look at something called the patient summary. The patient summary really brings together information that's there in the clinical information for the patient as well as the claims information for the patient into one view. And I'm going to talk about what the different sections mean in a patient summary. It is all the relevant care the patient has received, whether the source is from clinical or claims, in the last 1 or 2 years that the patient has received care. I am sharing my screen where you're able to view something called the patient summary report. This patient summary report is for Sarah, test patient, and we can see, for example, we have a list of problems. We have a list of problems that Sarah has, bronchitis and hypertension, like we saw from the CCD earlier. But she also has a whole bunch of other problems that came across in claims information. For example, the low back pain or acute bronchitis, which is actually that's from CCD. She had a wound, open wound. So additional information that was in claims is also aggregated into this one section as to what are the list of problems that Sarah could be having and what is the source of problems. Is it from the clinical information or is it from claims information? And where was it diagnosed? So you have information about the service provider as well. Now, if we go through the different sections likewise, you can see immunization. She got an immunization and you got to see the date that she received the immunization. If she has any allergies, for example, aspirin, what is the allergy? What is the reaction? And is it mild or moderate? You get to see that information as well. Medications. Now, this section is interesting because this information comes from medications that are ordered for the patient. So if there are any medications that a doctor ordered, it would come across in the clinical information and you'd see the list of medications that were ordered for the patient, not necessarily dispensed or picked up, but these were the medications that were ordered. The next section clearly says medications that were filled at the pharmacy. That means Sarah actually picked them up from a pharmacy. So it's more than likely that she's maybe currently on these medications. Now, the difference as to why you often see, more information in the claims information than what was ordered is that there might be providers who are not yet connected to the clinical data repository. So we might not have all the medications that were ordered for Sarah, but we will for sure know which were the medications that were picked up at the pharmacy by Sarah. Likewise, you also see any inpatient admits that Sarah had, any emergency department visits in the last year that Sarah had, and the last 2 most recent blood pressure readings for Sarah. And we've been told that A1C is a very common, clinical test that most clinicians are looking for to find a value. So if there were any tests done to measure A1C, you would see any data that would have come across in the results or lab section of the clinical data for the last 2 years. In this case, we don't have any, so therefore we're not displaying any. So this patient summary really brings together information, all the information we have on Sarah, both from clinical and a claims perspective. With that, I am going to pause and see if there are any questions on any data that you viewed in the clinical data repository.
Joe, there was one question in the chat about any information from military health records. I assume the answer is no, that it's only if it was done, if it was information that was collected while their coverage was Medicaid, but if you or Rick can answer that.
That is correct. If they were at any point a managed Medicaid client and they were seeking care in the community to get care, then that information would have come across and we would have some information, but otherwise, no. Rick, do you want to add anything to that?
Yeah, I would agree with that being accurate today. Just to be clear, we talked about the future. Obviously, the military and veterans are also deploying electronic health records, and those same electronic health records could contribute data to the CDR just like any other. I feel like we've had conversations for years with folks at Madigan and NVA and so on about possibilities related to exchange. And I believe that those organizations are connected to the national HIE networks. And so if there was a strong interest in that, that is a direction that we could pursue. It's technically feasible. It's not a limitation. It's not a technical limitation.
And Joe, there's a question that kind of harkens back to Rick and your introduction about the number of patients, but also what percentage of Medicaid providers are currently contributing to the CDR, just roughly.
Yeah, of course, the challenge is always the denominator, right? Because despite of all the money we spend on healthcare, it's very hard to know how many actual providers of care there are in our system or any other. I think what we would say is that generally we are talking to the larger systems. You know, Joe, would you agree? So most of the larger systems that you would think about, multi-care, the larger community clinics, Children's Hospital, those sort of places, Confluence Health and so on, would be submitting. It would be less common to have a small independent provider. It's not unknown, and again, that some of them are connected, you know, through other sources, as we've talked about. But in general, right now, it is the larger organizations that are seeing larger numbers of Medicaid patients. And we do have a list that you can see on our website that will identify specifically which providers are connected.
Any other questions for Joe about the technical aspect of what's in there? There's some questions about facility operation, healthcare providers' money, but I, for the moment, just want to make sure that we've answered any questions about the screenshots, about the website itself, and what information is in there. All right, Joe, I think that's the end of your main slides, right?
That is correct. So if there are no more questions, if we had time, I'd have gone into details of the tabs and the claims view, but in the interest of time, we're just going to stop here. And then, Mark, I'd like to pass this back on to you for concluding the meeting.
Excellent. If you can unshare your screen so we have a full screen again. Thank you so much, Joe. This was really clear, and I think a good, and Rick, a good kind of Cook's tour. So I guess I want to ask the healthcare providers and the jail administrators concerns, questions about the operation of this to help inform us. Healthcare Authority, WASPC, the MCOs, One Health Port. Is this something that we think is going to be valuable to you, especially at intake? And there's other potential values too. If it is, then we'll get to work on some of these issues, the confidentiality issues, the substance abuse issues, the cost issues, a bunch of other questions, some HIPAA questions. But really the main question that I'd like to have us answer today is this something that you see as potentially valuable? Is it worth our effort to try to work out the kinks and make it available to the correctional facilities in our state?
There's a lot of positive feedback in the chat for sure.
Right. Actually, that might be a good idea. If you just want to, from your facility, and I would ask one person per facility, and if your name tag on the way you signed in doesn't say what facility you're from, if you would just put that in, say, Clallam County Jail, thumbs up, we would like to pursue it. That would be really helpful to us. So there are a couple of questions out there, and I'll ask for some help from Joe, Rick, and Jason. The question of money keeps coming up, and so I'll try to paraphrase the answer and then let me know. As long as a facility is just using this the way that Joe just demonstrated, you go into the website, you sign on with your name, you look somebody up, there will be no charge for the jails. The only time or prisons or the juvenile system, all of whom are here. If, on the other hand, you ask your electronic health record provider to create a link between the CDR and your electronic health record, such that when somebody automatically comes in to booking, automatically that information syncs and it populates your electronic health record. In that case, there would be a charge, and would be based on the size, not actually the size of the jail, it would be based on your annual budget. There is a table, but it starts at around $600. And one of the kinks that we need to work out is it might not even fall necessarily on the jail to pay that. That's something that we need to have more discussion about. But provided that you're only using it the way that Joe showed, there would be no charge. So Rick or Joe, would you confirm if I got that right?
Sure. I mean, you understand it perfectly, Mark. That's great. I mean, one thing that's important, I mentioned that we are the lead organization. And when the legislature did that, they asked us specifically to find a way to make this affordable, not to just charge what the market will bear. So the best way to think of this, it's like a co-op. We have to collect enough to be able to support the costs of the organization. And so, what we have found is the cost burden of providing portal access is very limited. There's additional costs if we're connecting to an electronic health record. So yes, if all you're doing is using the portal, that just like Joe just did, if you were Joe, right, and you were sitting in your jail and you are looking up the identity of an individual who is just you're just doing intake in your jail on that person, you would not incur a financial expense to make that inquiry. If your jail has an electronic health record and you are in that electronic health record workflow, which is what clinicians who have electronic health records like to do, and so we wanted to connect that electronic health record to the CDR, the Clinical Data Repository, and the Health Information Exchange, so you could query, that Joe showed you that query, your system would be able to launch a query to call the information on that individual into your electronic health record workflow. Then you would pay, we would charge you the annual health information exchange fee that is on that table. And as I mentioned, it ranges from $600 for an organization under 10 million to $48,000 for an organization over $1 billion. So it's not a huge annual expense. We do not have transaction fees. We do not charge for per service. So if you were to use the Health Information Exchange to send to access the state's immunization registry or the prescription drug monitoring program, you would not pay extra for those services. That would be included as part of your annual HIE fee. It's sort of a all-you-can-eat model.
And even that fee is something that we need to talk about behind the scenes, but there may be other ways of covering that. But for the
Mark,
main use,
could I add something? This is Sharisa.
Go.
Yeah, wanted to just looking at some of the comments in the chart, or in the chat, want to make sure that the information that we're talking about will fall under HIPAA protections. So the people that will be able to view it are people who would be able to view HIPAA protected information. And so we can, obviously as we go forward, we'll get all those definitions out to you, but it wouldn't necessarily be a correctional officer. It would have to be some sort of healthcare provider. They wouldn't have to be on site necessarily when they did it. So I know for some jails that the providers might come once a week. So there are ways in which you could get information, but the only folks that can see this is all HIPAA protected information. So we'll just keep that in mind as we go forward with the discussions.
Yeah, thank you for bringing that up, Sharisa. And that was an important question I wanted to hit. And it is something that can internally that we'll need. There are a number of jails that there's kind of three groups of jails. There are those who have 24/7 healthcare on site. There are those who have healthcare on site, but not 24/7. And then there's some who have nothing, that only use, for example, send people on to outside providers. So certainly the first group is not a problem. That middle group that I mentioned, Sharissa just addressed, and the provider could still sign in. I think the group that we're going to have to do the most thinking about is that third group where there is no healthcare provider. So thank you for bringing that up. Other concerns, questions? We kind of have a couple of minutes of open time we've gotten. And Jason or Alicia, if I could ask you, I'm having trouble capturing the chat. If before you, Alicia, if you, before closing this session out, if you could capture the chat in a file, if that was possible, that would, I'd appreciate that.
I've taken notes too, Mark, so I think we can do that.
Great, thank you, because I'm not good at multitasking. So
No, lots of good interest from some jail representatives, so appreciate that. Mark, or maybe Dr. Fatinos or others, you maybe, can we touch on maybe 1 minute on the SUD data?
Sure. So I think one of the questions in the chat was, what about if a mental health provider includes substance use disorder data in their records? Right now, if there's any mention of a substance use disorder diagnosis that shows up by code, that is excluded wherever it comes from. I don't know how many behavioral health organizations right now are submitting data to the CDR, if any. So the mental health notes that would be in there currently would be diagnoses from clinical health providers, or if they have a social worker in their clinic or something, that would be there. So for other SUD data, it's just, like I said, we can't figure out which of those diagnoses are coming from places that have the 42 CFR Part 2 protections, which require individual consent. And that's, I believe, what Mark, actually Rick was mentioning earlier. We're trying to work on a pilot where we can start figuring out how to do consent management so we can get this really important information in there. I know that's one of the most significant things you all deal with, are people struggling with substance use disorders, and it seems like a big miss not to have that. We recognize that, and we're also bound by federal rules. So we're working to try and figure out how we can get that information where it needs to be.
Thanks, Teresa. That's going to be a tough one. I appreciate that you're working on it. Another issue that's come up that, again, is part of what we need to discuss in a smaller group afterwards is this whole issue of covered entities. Sarah from DOC brought it up again, and it's more than we can handle in this meeting, but it is something that we will be discussing if there is enough interest in pursuing it. We are about at times. Let me ask Jason, Rick, Joe, John, and Sharissa if you have any last thoughts that we should be thinking about before we close out.
I can just answer the quick question in the chat that buprenorphine would be in there if they picked it up as a claim. Methadone from an opiate treatment program would not be.
And would that be irrespective of which clinician and their 42 CFR status entered the BUP?
Well, right now we don't have a lot of clinicians working out of 42 CFR protected entities. There are a few, so they might not be in there, but the prescriptions are going to, if they come from a pharmacy and are filled and paid for by Medicaid, they're going to be in there for folks that have managed care. Good. I don't think we've got that sophisticated yet.
I think that's a good thing then.
Great.
Anything else? All right. Well, in that case, thank you all for coming. This is probably the first time that we've gotten most or many of our correctional healthcare people on one call that I can think of in my memory. Thank you, Jason, for getting us all together. Representative Davis for getting things started. John for your liaison. Joe and Rick for your presentation and for keeping the system up. And Sharissa for your brain power that you added to this and the expertise. Thank you, everybody. I think I'll go over this, but I think we have our marching orders, right?
Sounds good. Thanks, Mark. Thank you all.
Everybody.
Thank you.
Thank you.
Thanks, everybody.
Take
Bye.
care.
Thanks, everyone.
Appreciate it.